Cavernous haemangiomas. The title disappeared. Macroaneurysm and vasculopathies. So if you can do it less than 10 minutes, we can have questions. Otherwise,
it's very good. I thought I had 6 minutes, so thank you. Thank you for inviting me. And to do it very short, I could just say that my point is, if you have a patient with retinal exudation, I think you should do treatment. I also have some pictures and some other points, but this is the main point. Cavernous haemangiomas are these clusters of vessels or cavernous extending from the retinal vessels. They are sort of on top of the retina and they look like grapes, as we heard before. Sometimes they're just simply like grapes, others with a bit of whitish gliosis on top of the tumor. They're very rare. You can see that they look like nothing else. If you do a fluorescein angiography, you can see this very, very slow filling of the tumor. And because of the sediment of the content of the tumor, the fluorescein will be primarily in the superior part of the tumor, and this is called the capping sign. Often you don't need to do anything. Sometimes they have vitreous hemorrhage. It will gradually disappear by itself. In very rare cases, you will have gliosis that can lead to traction. But in most cases, there are no need for treatment at all, except for observation. You do need to know or remember, though, that if you have a patient that you see with this sort of tumor inside the eye, some of them have it in the skin also. You may notice if you look back from the slit lamp. But the most important thing is that some also can have it in the brain, so you should do a scan to rule out that there's a haemangioma in the brain. So next case is about retinal macroaneurysms. This is much more common. They extend from the arterioles, and they can lead to bleeding or exudation. And here on the FA, you can see that it fills very fast. So compared to the cavernous haemangioma, this is a high blood flow tumor, which may be the reason why they have leakage of exudate. Some people may have high blood pressure or cardiovascular disease, so you have to consider that when you have a patient like this. So what should you do? This is a new paper, and they described it very nicely. Either you can observe. This went very well in this case, so do nothing. You can give laser. It went very well in this case, but beware that it's destructive. So some people also try to give anti-VEGF, which probably works by reducing the permeability of the vessels and thereby making them non-leaky. This new meta-analysis based on 1,300 cases, I think none of them were randomized, so it's not good evidence, but it's the best evidence. I think they found that laser or anti-VEGF was best in relation to higher closure rate and better visual prognosis compared to observation alone. Yeah, moving on a bit about other kinds of tumors and exudation. This is a 60-year-old female who had a vasoproliferative tumor. You can see it in the inferior temporal region down here. Yeah. It was concluded that we didn't need to treat her because she had no symptoms. And I've written it in red because I think it's a mistake. But that's using the retroscope, you can say that. This is 2 years later. The exudation had progressed, and now she had macular edema. And this is often what will happen because of the Henle fibers. They all converge against the fovea. So if you have exudation, at some point it will end up in the fovea. So you might as well treat when you see it. Here we treated it, but because it was a very big tumor, we put on a ruthenium plaque, and then 2 years later and some additional surgery, the exudation had decreased a lot. Next case is a 45-year-old male who presented with this small annular ring of exudation here. and edema in relation to that. So we did optus-fluorescein angiography, and you can see leakage from the area where the exudation is. And if you look very closely, if you should just look at one image of fluorescein angiography, some technicians, they take like 50 pictures. But if you only have time to look at one, you should look at the one around 1 minute, where you see the phase between the arterial and venous phase. Here you can see the capillary filling, and you can see actually in this case microvasculopathy in the periphery in the same sector where the exudation was. So we concluded this was a Coates-like vasculopathy, very mild but with central exudation, so we gave laser treatment with slit lamp, not regular laser but laser with fluorescent in the venous to sort of promote the ablation of the vessels. So the point is not to treat the retina, but to treat the sick vessels and destroy them. This is what happened after a year, gradual decrease of exudation, and yeah, he preserved good visual acuity and no symptoms at all. So a case with a good result, yeah. Next here, it's more obvious that there is a microvasculopathy and a small vasoproliferative tumor. At this point, it was partly treated at another institution, and he came to us because of moving. We saw exudation here in the center and also here in the superior part. And what you can see is a microvasculopathy and the non-perfusion corresponding to adults-like Coats disease with this vasoproliferative tumor. Then we gave laser directed against the sick vessels and directed against the non-perfusion area, and it resulted in regression of the exudation. Again, laser with fluorescein, and in this case also with indentation to reach the far periphery. So that's it. Take-home messages are: remember to do a brain MRI if you have a Cavernous haemangioma, and in all other cases, almost, I think, you should treat if you see exudation.
Very good, Carsten. You made it possible to ask some questions. So for Teresa, I actually had one question. So which of the vascular tumors would you like us to send for the MRI? I think we will rephrase the question next year. Which vascular tumors in the retina should have an MRI?
So choroidal haemangiomas. I would like you to send the retinal vascular tumors, because the choroidal hemangioma is already good documented with MRI. There is one good article, and in our institution we already also evaluated some, and it's exactly the same. So I'm quite confident that we know already the characteristics on MRI of a choroidal hemangioma. The retinal lesions like the capillary and the cavernous hemangiomas, they are not good evaluated with MRI. Yes, in the orbit, so I expect them to be a little bit the same, because it's the same, but I would like you to send me to confirm.
But more for cerebral lesions?
No.
But
for
we
the
would
eye.
like to know.
The cerebral are already good documented. That we don't know more, we don't need more experience, but for the eye.
No, but from the clinical point of view, who should we send? So when we sit in the clinic, we have a problem, we see a tumor. So which tumors should we think we need a radiologist to tell us nothing is wrong in the brain?
That nothing is wrong in the brain.
Exactly.
That is the cavernous, the retinal cavernous hemangiomas, which can be hereditary, and that we can also have brain lesions, like we just heard. And the patients with von Hippel-Lindau, they have also many times spinal and cerebellar hemangioblastomas. And the Sturge-Weber also can have brain lesions, so they all can have brain lesions, basically. But I would like to study the ocular characteristics of these lesions better. And then we can perhaps conclude that you don't need the radiology, but at least I know exactly the characteristics that I expect if you anytime have a doubt. Or perhaps we can find an extra added value of MRI for the study of these lesions in the future, like we did in the uveal melanoma.
Thank you.
Martina? Yeah. So concerning the bigger choroidal hemangiomas, We have quite a good results with proton beams. So there's been a paper as well from the Paris study that's saying doing PDT in bigger ones, it actually adds a risk of recurrence, as you showed, and the visual acuity was better for bigger tumors that started off with proton beam. Do you share? I don't have enough long term, so we have like 5 or 6 years, we're fine. But I don't know if you, when looking back at yours, you have any long-term results with proton beam in big ones, and actually they kept a good visual acuity. What's your impression?
We had a couple of proton beam ones. Usually they were failed PDT, so I can't really, haven't got many primary protons. We've got a couple, we use a lower dose with protons, 20 gray.
Same as us.
We had a higher than we wanted rate of maculopathy, and that's kind of why we didn't really pursue it so much. Just radiation maculopathy, really, and so PDT is still our first line, but if it doesn't work, that's fine.
A question related to what a colleague has just said. In large hemangiomas, do you use overlapping PDT treatments?
So overlapping, I mean minimally overlapping, but like I said, you don't have to treat the whole thing.
Yeah.
The bulk of the belly of it is usually enough to get rid of the majority of the exudation.
Okay.
So we had the experience in Copenhagen that we didn't really kill the tumor. So now we have a very big safety zone around it, and that seems to help us a lot. So originally PDT was made for the CNV in age-related macular degeneration, and there was a safety zone of 200 microns around the whole lesion.
Yeah.
And it seems like the PDT, you need to kind of kill the supporting vessels in order to kill the lesion. That's at least our experience. Otherwise you can do it a lot of PDT and nothing helps.
I was asking this because we had one case not long ago. We treated it with a single PDT, but it was a bit larger than the PDT area. And the problem that we had is later on, we gave him an additional PDT with 2 overlapping fields, but it was pretty centered on the fovea, and we had a very big decrease of visual acuity.
Yeah.
Thank you.
So what you can experience in some of the larger choroidal hemangiomas, especially in kids, is that you can have a RPE tear.
Yeah.
And that is always a bit scary to look at, but they tend to be quite stable, but it's not very nice to see the RPE tear after PDT.
Thank you.
So I actually have a question with the juxtapapillary haemangioblastomas. So how do you treat those that are in close contact to the optic nerve?
We would perform PDT on those.
But would you include so that is a big question, would you include the optic nerve or would you not include the optic nerve?
Our medical retinal specialist does the PDT. So I don't know, but I think they do not include the optic nerve. They only take the tumor components.
Do you have much success with PDT? I mean, we've had 1 respond out of 6 or 7.
No, we do not have that many patients that are close to the optic nerve, so we have a limited series.
Yeah, but we have the same experience as they do in Liverpool, that the PDT for the juxtapapillary is not really very helpful. Unfortunately, we talked to the patient and asked them not to use the eye with the hemangioma in.
We have done protons, 20 gray protons with some of those because there's nothing else. But again, they get maculopathy. Maybe you could treat the maculopathy though. Or
So maybe you need the microphone so the rest of the audience can hear. So the question was about proton beams for juxtapapillary hemangioblastoma.
Yeah. So we fractionate. We do 20 gray innate fraction, which is a bit of a pain for the patients, but so far no maculopathy, but it's 5 years follow-up. It's not long term, but it's good.
I think we probably leave them too late, and so the vision never improves because you go, I don't want to treat it, I don't want to treat it, and then they get chronic subfoveal fluid, and then anything they get back is rubbish anyway. But nobody wants to treat a 6/6 eye with protons at the nerve, so I think everyone's a bit stuck on that.
And it's kind of everybody's nightmare, really.
So Carsten, what do you think about anti-VEGF and vasoproliferative tumors?
VEGF and vasoproliferative tumors.
Yes. Is that a good idea?
know. I don't think it's sufficient. I think it's like peeing in the pants, maybe. We don't use it regularly.
No.
Do some people do that?
Actually, I don't know.
I think we've had lots of referrals from people who do that, but I don't really see any VEGF pathology in it, so it doesn't really make sense.
So we had a patient that while we treated the tumor to have it reduced, he had developed neovascular glaucoma. And there we gave anti-VEGF to sort of bridge him over to the point where the tumor is not active anymore. We're still waiting for that part, but for that part it works, but only as a bridge treatment.
I think anti-VEGF has a role in PBT after the cryotherapy because they sometimes develop macular edema, and then you inject after that, but usually it's a cryo. That's our experience.
Thank you. That was end of this session. There will be a tumor session in the Grand Auditorium where we'll talk more about recent developments in ocular oncology. So please feel free to join us in about half an hour.
15 minutes.
Work that's been done by Bailey Freund and others that suggests that the